Hello, my name is Brad Langford, and welcome to the first in a series of lectures on the topic of antimicrobial stewardship. Today's lecture will be on the principles of antimicrobial stewardship. These are our objectives for today's talk. Firstly, what is antimicrobial stewardship? It is essentially a balancing act. By ensuring we optimize antibiotic use, by curing the infection, but at the same time trying to avoid any unintended consequences of antibiotic therapy, including side effects. But in addition to side effects like any other medication, antimicrobials have additional harms that we need to be concerned about, including C. difficile, alteration of the microbiome, and antimicrobial resistance. Antimicrobial resistance, because it can be transmitted from person to person, it becomes an issue not only for patients, but also for the population. So antimicrobials are quite unique in that they are the only drugs that have transmissible loss of efficacy over time. So in other words, the more antimicrobials we use, the less effective they become. Antibiotics really have second-hand effects that extend beyond the individual recipient. In this triangle here, I showcase a few of these examples. At the top, in the hospital bed setting, if you are a patient admitted to a hospital where the patient previous to you in that same bed had received an antibiotic, you yourself are at higher risk of having a C. difficile infection. Towards the bottom of the triangle, in the neighborhood setting, in neighborhoods where antimicrobial use is high, particularly fluoroquinolone use in this example, where fluoroquinolone use is high, patients who live in that neighborhood are more likely to acquire a fluoroquinolone-resistant infection, whether or not they have recently received a fluoroquinolone. To really understand antimicrobial use, it helps to understand the term selective pressure. Selective pressure is really survival of the fittest. Upon exposure to an antimicrobial, those susceptible organisms are killed, and resistant organisms thrive and multiply and take their place. This can happen in the patient setting. You can picture, for example, in the gut of a patient who is receiving antimicrobials, but it can also happen on a more macro level in institutions and in populations. We know that in those settings where antimicrobial use is higher, we're more likely to see antimicrobial resistance. So we can do at least three things to prevent and minimize the emergence of antimicrobial resistance. Firstly, to practice good antimicrobial stewardship to prevent the emergence of these drug-resistant infections. Secondly, practicing good infection prevention and control to prevent their transmission. And thirdly, vaccinating to prevent colonization and infection with these potentially resistant organisms. When thinking about decision-making related to prescribing, there are really three key aspects. This includes initiation. Does this patient need antibiotics? Selection. Am I using the most effective and safest antibiotic in terms of the drug, the dose, and the route? And then duration. What is the shortest, most effective length of therapy that I can use for this patient? When thinking about these three key aspects, initiation is really the most important, because if we've done a good job selecting the appropriate antibiotic and choosing the right duration, and the patient did not need an antibiotic in the first place, we've really done a disservice to the patient and caused unnecessary exposure to that patient. In most settings, including the hospital and the community setting, up to 50% of antibiotics used are either considered inappropriate or unnecessary. So this means it's crucial to understand whether or not patients meet the clinical criteria for infection. It's important to know that not all positive cultures need treatment, and distinguishing between colonization and infection can be very important. We know that in most hospitalized settings, the most common indications are urinary, skin and soft tissue, and respiratory tract infections. So knowing these guidelines really well can be helpful from a stewardship perspective. Antibiotic initiation is really the most challenging aspect of antibiotic overuse but can have the most significant impact on antibiotic exposure because we can reduce antibiotic exposure before it even starts. Now switching gears to selection of antibiotics. This mnemonic here, Dr. Plasmas, can be really helpful to trigger a thought process around what appropriate antimicrobial should we be selecting for a given patient. So there are a number of factors to consider. We won't go through each of them in detail in this specific lecture, but suffice it to say, they really focus on three key things: the safety for the patient, the efficacy against that particular organism, as well as the safety for the population. So when selecting an antibiotic, we should really distinguish between the terms empiric and targeted therapy. Empiric therapy is an educated guess based on the best available information that we have at the time. This is usually before the culture and sensitivity results come back, or in situations where we don't require or are unable to get culture and sensitivity results. So in these situations, we're using an educated guess based on the hospital antibiogram, thinking about what organisms potentially could be causing this infection, looking at previous susceptibility reports that patient may have had, and also thinking about selective pressure for that patient in terms of what antimicrobials they may have received and what settings they may have been in that are more likely to harbor more resistant organisms. Once we get the culture and susceptibility results back, we're now thinking about things from a more targeted perspective, and we're prescribing based on patient-specific information. So now the current susceptibility report becomes important, and the previous antibiogram that we were using becomes less important. Now, thinking about duration of therapy, duration should be long enough to cure the infection, but not any longer because we want to minimize any impact that we have on the gut flora. We really know now from many randomized controlled trials, we know that shorter courses are usually equally effective to longer courses, cause less antimicrobial resistance, less side effects, and induce lower rates of C. difficile infection. In many cases, we will see a fixed antibiotic course at the outset, but we can tailor the duration of therapy based on patient response. So it's really a myth that this common myth that we've been counseling patients for many generations about finishing a full course of antibiotics to prevent resistance, this is in fact not true. In fact, it's the longer courses that lead to greater rates of side effects, greater rates of antibiotic resistance and C. difficile infection. So we should really be using the shortest effective course whenever we can. So we won't go through these in detail in this lecture, but here are some common duration recommendations for some of the more common infections that we'll see in the hospital setting. One of the arguments to using shorter courses of therapy is that, well, it's only another couple of days before we reach a full 7-day course. The patient's doing well. Why don't we just keep it going? But we now have some good evidence from large cohort studies and randomized controlled trials that show that every individual day of antibiotic therapy counts in terms of additional risk of treatment. So, for example, in a study in the United Kingdom of patients with pneumonia, each additional day of antibiotic therapy caused about a 9% increased risk of C. difficile infection. In the middle, in children who've received beta-lactam therapy, they're at an increased risk of pneumococcal resistance to penicillin at a rate of about 4% per day. And then similarly, in patients who are hospitalized who've received anti-Pseudomonas beta-lactams, they're about 4% per day increased risk of acquiring an anti-Pseudomonas antimicrobial resistance. So we really know that each individual additional day of antibiotic therapy counts, and this information could be helpful to you to potentially arm you in these discussions to ensure that you're using the most short and most effective duration of therapy for your patients. So when thinking about antimicrobial stewardship, we need to think about behavior change. It's essentially more than just providing information and hoping that clinicians do the right thing in terms of judicious antibiotic use. Here I present to you the COM-B model, or capability, opportunity, and motivation, which is a behavior change model. So capability, do I know and do I understand what I should be doing? Opportunity, is it easy to change this behavior? Has the environment allowed me to make this behavior change? And in motivation, what incentive do I have to change this behavior? So I'll give you an example that's more personal to me, is I have a tendency to eat a little bit too many chocolate bars. So from a capability perspective, I really know that I should be changing my behavior. I know that, too many chocolate bars is not good for me. But is that enough? Surrounding myself with many chocolate bars. I have too many chocolate bars perhaps in the pantry. And motivation. Do I have the motivation to behavior change? So am I thinking about what effects this might have downstream in terms of weight gain or cholesterol levels? So really thinking about these things from a stewardship perspective can be helpful too. That it's not simply about knowledge and education. We need to think about some of these more complex aspects of behavior change. So for antimicrobial stewardship interventions, we can divide them into a couple of buckets. Firstly, those that address antibiotic use before the prescription started, and those that address usage after the prescription. Sometimes it helps to have a mixture of different strategies in place, so a multimodal approach, and often stewardship programs will pick some from each of these two buckets. But in general, there's really no one-size-fits-all approach for each individual stewardship program. Pre-prescription, we can consider things like education, restriction with pre-authorization, so ensuring that high-risk or targeted antibiotic use is prevented and requires an approval before being started. Guidelines and order set to guide the appropriate selection of antibiotics. Microbiology reporting strategies, including cascade reporting or selective reporting. Antibiograms to help in selecting of empiric therapy. Post-prescription, things like prospective audit and feedback are very common in antimicrobial stewardship programs, which involve reviewing patients who are receiving antimicrobials and making recommendations directly to the prescriber to optimize their therapy. Rapid diagnostic testing can help us find out earlier in the course of therapy what organism may be causing an infection. Restriction with post-authorization is essentially restricting particular high-risk agents, but reviewing them after the antibiotic prescription is written. We know that many patients will report allergies, particularly penicillin allergies, but we know that a small proportion of those are actually true IgE-mediated reactions. So many of these patients can have their allergies verified and cleared from the record, and they can often use more appropriate beta-lactam therapy. Intravenous to oral switch can be important to help from a patient comfort perspective, a cost perspective, and also sometimes a length of stay perspective. Dose optimization to ensure that doses are appropriate from a pharmacodynamic and pharmacokinetic perspective, and therapeutic drug monitoring for agents that may have narrow therapeutic windows like vancomycin and aminoglycosides. So with that, I'll leave you with a few key reflections and change ideas. So remember that antibiotics are life-saving drugs, but really need to be protected for future generations. So we're thinking about the patients in front of us, but also those who are our future patients, where we want antimicrobials to be effective for them as well. So think about situations in your practice where you might have seen some of these secondhand effects of antibiotics. We know that stopping antibiotics, unnecessary antibiotics before they start, can be really the biggest bang for the buck. So think about some opportunities in your practice where this may be something that you can address. And then also remember this CALM-B model, or the behavior change model associated with capability, opportunity, and motivation. Consider how you might better influence behavior change in your role. And also what antimicrobial stewardship program interventions that you might already be doing. Which ones could you be doing more? So with that, I will close the lecture and thank you for your time and hope to talk to you in the next lecture.